one of the 5th years, and I'm intercalating at the moment in emergency medicine. So I'm spending the year in A&E. I'm going to be doing a little bit about ABG interpretation today. Let me just make my screen. Let me just make my PowerPoint big. I've kind of gone, the way I've approached it is I've gone through kind of how I would approach an ABG in an exam, because the way that I've learned for kind of finals and things has always been quite like exam focused. I've not gone into the pathophysiology of things too much. If that's something that you're like a bit confused by, like I can try and give you what I know, but there's a lot of like resources out there, and I'm not claiming to be an expert in anything, so just a disclaimer. But yeah, so, and then I'm going to go through some cases at the end, so I'd really appreciate it if you guys could like get involved with like kind of going through the ABG and the interpretation, and then we'll just have a little chat about differentials and then kind of go from there. I've got 4 cases at the end, so yeah, that will be kind of the structure. Shouldn't be more than like 40-ish minutes, so yeah, okie dokes. So when I look at an ABG, the first thing I always do, and particularly with this is with an exam kind of focus in mind, I'll look at the clinical condition of the patient, because I think that gives a lot of context to the ABG result. Often, once you start doing questions in exams, I think I sort of started to realise that they have a massive trend in what they include, and most of the time by the time I sat my exams, I'd be able to look at just the clinical context and be able to probably guess what the ABG was going to be, just because they have such a pattern in terms of what they give. It is quite helpful in the ED or like when you're looking at an ABG as well, just to be aware of like history of a patient and stuff, just because it makes it a little bit easier for you to understand what you're looking at. So yeah, like looking at the age of the patient, are they really young? In an exam, if you've got a 5-year-old or a 10-year-old, are you thinking they could have a DKA? Because that's quite a common exam question. Are they short of breath? Are you thinking that they could have a respiratory, could have a respiratory kind of problem going on? Do they have known COPD? Has this been a problem for a while? That's all quite important. Are they a known diabetic, as I say, DKA? Another one they love is kind of like anxiety can cause changes in ABG. So they might say like, oh, a 19-year-old medical student presents to A&E, it's the week of their finals, they're very like, and that will be sort of like, that's a little kind of tip to sort of look for, like just always read, make sure you do look at the clinical condition, don't just jump straight to the ABG. Okay, and then when you're looking at an ABG, I'm just going to go through the basics of kind of what drives the background of an ABG. I'm not going to go into this in too much depth, but there's so much out there about this if you are confused, like YouTube videos and stuff to help. So CO2 is generally reflecting kind of the lung function, and HCO3 reflects the kidney function. So pH is a disturbance in one of these things. So CO2 will increase the acid or the hydrogen ions, and therefore the pH will drop. So when there's more CO2, that shifts this equation, which means that the H plus increases, whereas the HCO3 mops up the acid, which is the H plus, getting rid of it. So it makes it less acidic, more alkaline, so the pH will rise. There's a little kind of mnemonic, I don't know if it's a mnemonic, but yeah, called Rome, which a couple of people I've seen use in the past. So respiratory, opposite. So you have a low pH, therefore you have a high CO2, or you have a high pH, which is caused by low CO2. So respiratory is the opposite. Whereas with metabolic, if you have a low pH, it will correspond to a low bicarb. And if you have a high pH, it will correspond to a higher bicarb. So it's just knowing that CO2 causes the opposite effect on pH, whereas bicarb, it's the same. That's quite important because it can be a little bit confusing when you're looking at a question. Just know that, I think as long as you can remember that CO2 correlates with acid, and then that lowers the pH, so knowing that a lower pH is acidotic, that would help. I know that it can be a little bit sort of, so if you just kind of wrote that down in an exam, because sometimes your brain's just not functioning in that sort of way, if you're just writing that down, that might just help you to sort of remember the basics, rather than trying to remember how to understand this equation in an exam. Okay, and then, so when you're looking at an ABG, the first thing I always do is look at the pH. So if it's a low pH, they're acidotic. If it's a normal pH, that's 0.35 to 0.45, and then alkalotic is greater than 7.45. when you're approaching this, if you have the 4 key things that you're looking for in an ABG written down, you can cross them off. So you could say, if you know the pH is low, you can cross off the 2 alkalosis ones, which might make it easier for you, because then you're going forward with that kind of, you've cut some things out in your head. I'm going to have this sort of interpretation thing on for all of the interpretation slides, because I think it's quite a nice sort of way of going through it. So once you've decided on the pH, you need to decide, is it respiratory or metabolic driving this? Respiratory changes, as I said earlier, are due to changes in the CO2, because that releases hydrogen ions, which makes it acidic, or can reduce hydrogen ions, which can make it less acidic. And metabolic changes are due to HCO3 levels, because that makes it more alkalotic. So yeah, CO2 will bring the pH down if it increases, whereas bicarb will bring the pH up if it increases. So that's kind of the next step. So the next thing I do after I've looked at the pH, the next thing I do is look at the CO2. If the CO2 is increased, then you know that, and the pH is decreased, then you know that it's probably a respiratory force behind the pH being low. Whereas if the CO2 is decreased and the pH is increased, you know it's probably the CO2 is too low, and that's why it's caused the pH to rise, because there's less hydrogen ions to mop up that HCO3. So if the CO2 levels don't correspond with the pH, then that could be a sign that there's compensation. So that's just something to be aware of. Compensation is, with respiratory compensation, it occurs quite quickly. So you could have someone who's got a metabolic acidosis, and they could be breathing quite quickly to try and blow off some of that CO2 to bring the pH down. And then if the CO2 is normal, then there's no compensation and it's not the cause. So that's kind of something to just be aware of. So yeah, if you have a look here, if the pH is low, you know it's acidemia. If there's a high CO2, then you can say that that is a respiratory acidosis. So that's quite easy. You've got that then. You've looked at the pH, you've saw that it's an acidosis, and then you've looked at the CO2 and you've seen that that's the cause because it's high. So therefore you can say respiratory acidosis. If the pH is high and there's an alkalemia, and then you look at the CO2 and that's low, then you can immediately say that there's a respiratory alkalosis, because that's the driving force that correlates quite nicely. The next thing to do is look at the HCO3. Even if you found that there is a respiratory acidosis, I would always recommend looking at the HCO3 to see if there's any compensation. So HCO3 will increase. If you increase the bicarb, it will increase the pH, and if you decrease the bicarb, it will decrease the pH. If the bicarb does not correlate to the pH, then there might be a respiratory cause with metabolic compensation. So exactly the same as I said with the CO2, but the opposite. So if the CO2 doesn't correlate, then it's probably a metabolic cause. If the bicarb doesn't correlate, then it's probably a respiratory cause. Metabolic compensation does take a lot longer than respiratory compensation. So therefore you can assume that they've had a chronic problem with their lungs, and it's a chronic respiratory issue if there is metabolic compensation. Base excess is just another marker of metabolic acidosis or alkalosis. So if the base excess is high, then that correlates to high bicarb. So you've got a metabolic alkalosis, or there's respiratory acidosis with compensation. And if you've got a low base excess, then you've got a metabolic acidosis or compensation from a respiratory alkalosis. So just being aware from that, kind of respiratory compensation can be quite fast, metabolic compensation can be quite slow. I think they're two things to be quite aware of. And then, yeah, this is just, again, as I said, going through this sort of way of thinking. You've looked at the CO2, you've looked at the HCO3, and then you're always looking for compensation. So if the other one is abnormal, why? It's not correlating. Okay, and then I look at oxygen last. In hospital, that I tend to find that doctors will look at oxygen first, because if the patient is hypoxic, that is going to kill them first. That's the most immediate threat. They could go into an arrest from that. You should have a PaO2 of greater than 10 when you're on room air. If they're on oxygen therapy, it should be 10 less than the percentage of inspired O2. So let's say they were on 40% of oxygen, you'd expect them to have a O2 of 30. I never really got taught oxygen delivery devices, so I've done a little slide just kind of going through that in a little bit of more depth. So because I think it's quite an important thing to know, because it will be relevant in hospital. So just going through these are just some of them. So yeah, you can have nasal cannula. That the max you can give someone through that is 4 litres, unless you're in ICU and they've got high flow nasal cannula. So yeah, most you can give through a nasal cannula is 4 litres, and that would only correspond to 36% of oxygen. I'm not telling you to learn these numbers, you definitely don't need to know them, but it's just good to know that with a nasal cannula, maximum you can give is 4 litres, and that would correspond to 36% approximately. So it's just knowing that if you saw a patient who was on 4 litres of oxygen in a nasal cannula, knowing to look at their oxygen and take 10 away, as I said previously. Patient on 4, so it would be 36% of oxygen, so they'd expect to have an O2 of 26% thereabout, 26 or thereabouts. And if it was lower than that, then they would be hypoxic still. And then, yeah, a simple face mask, you can put 15 litres through it, like a Hudson mask is sometimes what it's called, but the max you'll get is 40 to 60%. And then a reservoir or non-rebreather, which is the one that they like in kind of like trauma situations, or if you're unsure of patients' oxygen concentrations, or they're in arrest or something like that, you'd always use 15 litres non-rebreather. And that can give it's meant to give 90%, but it's all dependent on how well it's used, because you have to ensure there's a good securing of the mask to the face, and there's not any air that's escaping, which is quite difficult to do. So it's just being aware that it's probably not going to give you as high, but it will give you quite a good amount of oxygen. Venturis are just kind of something for exams to be aware of in terms of COPD. There are loads of different concentrations, and you can titrate people's oxygen up or down with it. And they just basically, on the side of them, if you're ever confused, they tell you the number of litres because they'll have different amounts of different litres of oxygen that you need to put through them. So just having a look on them and seeing what it says if you're not sure, just to get that kind of concentration of oxygen through it. This is not really related to ABGs, but I just thought it was something to go through while we were on the topic of oxygen, and when you're looking at someone's oxygen on an ABG. With relation to that, I'm just going to have a touch on respiratory failure. So there are 2 types of respiratory failure. The first one, the oxygen is low, so you've got hypoxia, but your CO2 levels are normal. So you've got hypoxia and normocapnia. So that is due to a VQ mismatch, which is where the ventilation and the perfusion don't match. So the causes of this are, there could be a reduced ventilation and a normal perfusion. So that could be because there's edema stopping them from being ventilation, or bronchoconstriction with like asthma that's stopping the perfusion from, and the ventilation from, so the air from getting to the bases to the alveoli. So that's why you're not able to get that oxygen in, which is why you get that. However, because CO2 can still come out, you keep that normocapnia. Or you can have reduced perfusion with a normal ventilation, so a massive PE, or even just a small one, but more likely with kind of a massive PE that you'd get hypoxia, but their CO2 is still able to be removed through other sources. Whereas with type 2 respiratory failure, you've got hypoxia and hypercapnia, so you've got a low O2, but you've got a high CO2, and that is due to the lungs or the respiratory pump failing. So you have reduced ventilation of the lungs. So that's kind of, there's loads of different causes for that, like tons. The most common one that you'll see in practice is COPD. You'll see COPD patients who have airway obstruction and they have type 2 respiratory failure. But you can get it with obesity, pneumonia, fractures. You can get neuro sort of problems which can cause it, because you just don't have that same respiratory drive because of Guillain-Barré, motor neuron, your muscles just aren't working as well. Or you can have a kind of, the respiratory center isn't working as well, opiates and things like that causing respiratory depressions. So just to be aware that these are they really like to ask about this in exam questions. Not so much in terms of like the pathophysiology, but just being able to spot a type 1 or type 2 respiratory failure on an ABG is a really important thing and it's not something that's difficult, it's just something you need to learn. Type 1, low O2, normal CO2. Type 2, low O2, high CO2. Okay, just some things to note when you're looking at an ABG. A normal O2 on a patient in oxygen is really abnormal. So I saw a lady who came into ED with COVID and she was on 15 litres, which should have been about 90%, but maybe around 60. And her oxygen on her ABG was like 6. So like she really was not saturated, like her oxygen levels weren't enough. She was very hypoxic. However, 6 probably is within the normal range. So it's just being aware that if it looks normal, you need to be aware of what oxygen they're on, and definitely making sure to do that. Especially in A&E, you don't want to miss the fact that someone's hypoxic because it is, as we said, a threat to life. A normal CO2 in a hypoxic asthmatic patient is a sign that they are tiring. They should have a high CO2 because they shouldn't be able, it's quite a similar respiratory, their pumps aren't working anymore, their lungs aren't working anymore, so it should be high. And if they're tiring, their CO2 dropping is quite worrying. So that's one of the like criteria for life-threatening asthma. I'm pretty sure, double check that, but I'm pretty sure it is. So like just being aware of that, like I think that's quite important. And a very low oxygen in a patient who is looks completely well, has no shortness of breath, and has normal oxygen saturations is more than likely a venous sample. So if you look at someone and you think you're fine, your sats are good, you sat up chatting to me, you're not short of breath, more than like, and then you run an ABG and it comes back really low, it's just being aware that that could be a venous sample, and just you could have not hit the artery when you were taking it. So might have to do it again, just depending on what the indication is and things. And that is the only, I've found they are kind of starting to favour venous samples more, particularly in ED. I think it depends on the doctor you're with, but unless someone is on a massive amount of oxygen or it's going to change their therapy in any way or anything like that, they're kind of favouring venous samples just because they don't cause as much pain to the patient. And you can just take it when you're taking all their other bloods as well. Yeah, so that's just kind of a run through of ABGs. Is there any questions before we move on to cases? Just anything that I can, I can try and answer your questions, but. Any questions?
Yeah, there's a few. So someone's asked if you can run through that again. How do you know straight off whether they are looking at an arterial or venous sample?
So you need to look at the oxygen levels. So in a patient so if you look at someone and their oxygen sats are normal and their oxygen on their sample is really low, then it's more than likely venous, because that's the one thing that varies. Like a venous sample will give you a low O2 because you've got to think the venous blood has already oxygenated all the tissues and it's going back to the heart and lungs to be reoxygenated. So the oxygen in that sample is lower. So it's always going to have a lower oxygen than you would expect. So if you meet someone who is particularly unwell and then you do an ABG on them and their saturations are really low and then it's really low, it would make sense. But if they have normal sats and they seem well within themselves, but you do an ABG and it's really low, just being aware that that could be the case. You could have a venous sample there. So basically it causes a low O2, lower than you would expect.
Okay. So someone else isn't quite sure why normocapnia was worrying in an asthmatic patient.
It's because it's a sign that they're tiring. So it's just basically, so when you have an asthma attack, the first thing that happens is you start to breathe really quickly because you're anxious, you can't breathe, etc. Then it will go, so the CO2 levels will drop first, then they'll go high, and that's a sign that their lungs aren't working as well. And then when they're getting particularly unwell towards the end, they're tiring, and their CO2 just, it's like not as high because they're tiring. To be honest, I don't actually know why that happens. Does anyone else? I'm pretty sure it's just because they're tired. I just learned it was because it's a good sign. It's a sign that you might need to intubate someone. So if they're CO2,
I think it's because they can no longer like blow off the CO2, so it's starting to increase. That's what I thought anyway.
okay, yeah.
Can I say something?
Yeah, of course you can.
Yeah, I think it's because in asthmatic patients, their carbon dioxide levels are normally their CO2 levels are normally like high, and if you see that an asthmatic patient is normal capnia, that means they are losing their drive to it's called hypercapnic drive, if I'm not mistaken. They're losing the drive to breathe. I think that's it.
Yeah, that makes sense. So that's the drive they have, and now they no longer have that drive. So it's quite worrying. Yeah, that would make sense, wouldn't it? So just, I think, to be honest, being aware for your exams that it's a sign that they're tiring, and it's all, to be honest, in general, being aware of the fact that it's a sign that they're tiring and it's a sign that you need to intubate is just kind of what I would say has been an important thing to be aware of, and knowing that it's criteria for life-threatening asthma. That's more likely kind of how the amount of detail that I think you'd be expected to know at medical school level. Obviously going forward to kind of like specialty training and stuff might change, but yeah.
There's a couple more. I don't know if you want to take them now or at the end.
Are they ones that kind of determine the interpretation? I can have a look actually myself. Let me just have a look, and then I'll just. I don't know.
I think maybe if we like carry on and then.
Yeah, that's fine. Because I don't want to just take questions the whole time. Yeah, so if anyone wants to kind of speak up now and answer this. So first case is a 19-year-old female. She's come in with shortness of breath and pleuristic chest pain. She's recently returned from Australia. She takes the combined oral contraceptive pill, and these are her observations. So her respiratory rate's a little bit high, her heart rate's a little bit high, her sats are a little bit low, her BP is okay, and her temp's okay. Does anyone want to talk me through this ABG, like as if you were kind of interpreting it?
Yeah, sure, I can go ahead with that. So pH is 7.49, it's acidotic. PO2 is slightly low, but on the normal borderline. PCO2 3.9, again on the borderline. Bicarb is normal. Base excess is more of acidotic. So my overall impression is this is a metabolic acidosis.
Okay, so if we just like kind of go through it from the start. So you said the pH. Did you say it was acidotic?
Sorry, it's alkalotic.
Yeah, so it's an alkalotic pH. And then if you look at the oxygen's a bit low, but that's not the next thing you're looking at. So if you're looking at the pH, the next thing you're going to look at is the CO2. Now, I know you said that was borderline, but it is still low, lower than the normal range. So I would say that that was a low pH, low PCO, like no CO2. And then the bicarb is normal, and the base excess is actually also normal because it's -1, and it's -2 to +2 is the normal range. So it's actually a respiratory alkalosis because the CO2 is low. Does that make sense?
Yeah, I agree. Sorry, I didn't have my glasses on. I
Yeah.
just put them on. So
That's
Yeah.
right.
Yeah, you're right.
Yeah. And then the fact they are also hypoxic is just something to notice. So, and the fact they've got a little bit of low sats as well, like you'd probably be thinking about giving them some oxygen. Does anyone have any idea on a differential?
People are saying PE.
Yeah, so it's a very bog standard PE case, pleuritic chest pain, long haul flight. She takes the pill. With a PE is one of the common causes of a metabolic alkalosis, and that's because your respiratory rate's so high. So another thing just to note is that the respiratory rate is quite fast, and the heart rate is also quite fast, and tachycardia is also quite common in a PE. So these are just some things to be aware of. They're not related to like ABGs necessarily, but just knowing the typical sort of presentation of a PE and the risk factors would definitely be something I'd recommend getting familiar with and comfortable with for finals. So it's a respiratory alkalosis, and there's no compensation because the bicarb and the base excess are within normal range, and the differential is a PE. Fab. So just a little bit about respiratory alkalosis. So it's due to excessive alveolar ventilation or hyperventilation, meaning that you're blowing off the CO2. So it's being exhaled. This means that the CO2 is reduced and the pH increases, causing an alkalosis. So increased pH, decreased CO2 causes. So they can have panic attack, as I was saying earlier. That typical kind of medical student case, they really like that one for exams. Pain can cause respiratory alkalosis. Hypoxia to attempt to compensate can sometimes happen. A PE, pneumothorax, or you can cause it with excessive mechanical ventilation because you're removing too much CO2. So that's case one. Second one, would anyone like to speak me through this one? Anyone, even if you want to just put it in the chat or something, kind of, or if you don't like have 100% an idea, like just speaking it aloud might help you.
We have a few people in the chat saying metabolic acidosis.
Yeah, so it is a metabolic acidosis. Is there anyone picked up on anything else that's going on in this sort of picture?
They've said respiratory compensation.
Yeah, so so this is, so if I speak it through sort of how I'd approach it if I was in an exam, so I'd say sort of like the pH is quite low, which is indicating an acidosis. Next thing I'm going to do is look at the CO2, which is low, which doesn't correspond with the pH. So there could be some sort of compensation happening, but I'm going to look at the bicarb now, which is very low, which indicates to me that there's a metabolic acidosis. And as the CO2 is low, there's clearly some sort of compensation trying to occur. So that would be what I'd sort of say. There's a metabolic acidosis with respiratory compensation. So anyone have any ideas of the differentials?
People have been saying DKA.
Yeah, so this is a typical DKA case. Young patient comes in, they've got abdo pain. He's got a fever, which has probably triggered this DKA. Very non-specific symptoms. You do a gas and that's sort of what shows up. So just, really important to be aware of this. It's a really important presentation and very important not to miss because it can be quite dangerous. So metabolic acidosis with a partial respiratory compensation and DKA is the presentation. So metabolic acidosis can occur as a result of increased acid production or ingestion or decreased acid excretion or rate of GI or renal HCO3 loss. So you've got a decreased pH, a decreased bicarb, and a decreased base excess. Does that all make sense? Fab. All right then. So next thing you're kind of looking at is the, this is just something that I am claiming to be no expert on. This is the level of knowledge I learned it in for my medical school finals. I learned it as what the anion gap is, what it means in terms of if there's a normal one, what it could be a cause, what the causes of a normal anion gap and what the causes of a raised anion gap. And that is as far as I went. I'm sure there's loads on the internet that will teach you all sorts about it. It's basically so you add together the positive ions and you take away the negatives, and that gives you a number. The normal range is 10 to 18. If you have a normal anion gap, it's due to a loss of bicarb. And if you have a raised anion gap, it's due to an increase in the acid. So you get metabolic acidosis. There are two causes. You can have an increase in acid or you can have a decrease in bicarb. And normal, decrease in bicarb, raised, increase in acid. Loads of different causes. Something to sit down and learn for an exam. I don't think it's something that I've ever seen used in clinical practice, and I wouldn't be concerning yourself with too much depth about it. Personally, obviously everyone's a different kind of a learner, but my understanding of it is just sort of as this slide kind of summarizes. So yeah, I think as long as if you know the normal is due to a loss of bicarb and the raised is due to an increase in the acid, the causes become quite a bit easier, because you know that you can lose bicarb from GI losses or renal tubular acidosis, Addison's, and then an increase in acid, shock, sepsis, hypoxia, you're getting a lactate increase, renal failure. So, I mean, definitely something to be aware of, but not something to worry yourself with. Don't get too bogged down with it, in my opinion. I don't think it's as important as a lot of the other stuff that we've spoken about. Yeah. This is the third case. Would anyone like to speak it through?
Yeah, I can have a go.
Yep.
Okay, so the pH is more than normal, so it's alkalosis.
Mm-hmm.
And the PCO2 is within the normal range.
Mm-hmm.
The bicarb is above the normal range. So it's metabolic alkalosis.
Yeah, brilliant. Exactly. And then having a quick look at the O2 to make sure it's normal. Just making sure you say that if you're like presenting it in exam kind of settings and stuff, just so they know that you're thinking of it. Just makes you sound a bit slicker and stuff. But yeah, that's perfect. Exactly. So it's a metabolic alkalosis. There isn't really a differential in this case. Persistent vomiting causes metabolic alkalosis. So it's probably due to the fact they've got an ulcer and it might have ruptured or perforated, or they've just got a significant GORD as a result, or gastritis. So it's just, yeah, metabolic alkalosis due to persistent vomiting. I'm going to give you a little bit of information about metabolic alkalosis. So due to decrease in the hydrogen ions, or due to an increase in the bicarb. So decrease in acid, increase in bicarb. And the causes, you have the following characteristics on an ABG. So increased pH, increased HCO3, bicarb, increased base excess. Causes, GI losses of hydrogen ions, renal losses of hydrogen ions, loads of different causes, or you can have it due to kind of giving excess alkali. But yeah, they're just some causes to be aware of. So GI losses is sort of the one that they like in an exam. I've seen that one used, or diuretics. They're the ones I've seen used in an exam. And the others are just sort of ones to be aware of, but less commonly seen in exam questions, but obviously still good to learn. Okay, and there's a final case, and then we can just do some questions and call it a day there. So would anyone like to have a go at giving this, interpreting this ABG? So yeah, it's a 64-year-old male who's come in with worsening shortness of breath, increased sputum production. He's got a past history of COPD. Yeah. Anyone want to give it a go? Just kind of going through the ABG with that kind of systematic way of thinking. If not, put stuff in the chat, but it'd be great if someone would. It's good practice.
I can have a go. So pH is low, so it's acidosis. Oxygen seems low. Carbon dioxide is above normal. Bicarb is slightly above. So I'd say it's respiratory acidosis.
What do you think that bicarb might mean?
So because it's high, it might be with some compensation.
Yeah, exactly. So it's a respiratory acidosis with a partial compensation. If you look at the kind of history of the case, they have a past medical history of COPD. As I said earlier, respiratory compensation takes a while. So this patient has been hypoxic for a little while for them to be compensating. So that's just something that's quite important to be aware of, because it shows that this isn't a new thing. This has been going on for a little while, and sort of good to be aware of. Because if there's no compensation, it's a sign that this is quite a new thing. Yeah, and does anyone have any ideas on the differential? I mean, it's not anyone. You can just pop it in the chat. I can have a quick look. Yeah, so exacerbation of COPD, someone said. So exactly. Does that make sense in everything that I've said so far? So yeah, and yeah, another thing to note, because that could be the only thing they want you to differentiate. They could have two answers, both saying respiratory acidosis with partial metabolic compensation, and one says type 1 respiratory failure, one says type 2. So this has a hypoxia and a hypercapnia. So that's low O2 and an increased CO2. So they've got respiratory failure, which is affecting the actual lungs, like the alveoli and the ability to move the air in and out. Yeah. So respiratory acidosis, inadequate alveolar ventilation leading to CO2 retention. So there's an increase in the CO2, which causes a decrease in the pH. Causes, there are so many causes, but yeah, these are just some of the ones that I've put down. So respiratory depression, GBS, asthma, COPD, and yeah, ventilators can cause all sorts of issues. So just making sure you're on the right ventilator settings. That's why patients who are in ICU and crit care constantly get ABGs, just to make sure that they are on the right kind of and how they're getting on as well, and if they need to be stepped down. So just something to be aware of. That's everything that I've got covered. I'm more than happy to take a few questions. Yeah, anyone, just let me know any questions. I'll have a look. Actually, I'll just have a quick look in the chat now, because it's probably easier for me to do it. Okay, so someone's asked, the CO2 and HCO3 were out of range on the last case. How did you know it was a respiratory acidosis and not metabolic? So if we have a look at the question, the reason being is that the bicarb is high, not low, and a high bicarb will increase the pH, not decrease the pH. So it's the opposite effect. So that's why you know it's compensating, because it's doing the opposite. Whereas CO2 being high will cause an increase in acid production, which makes it more acidic. Does that make sense? Yeah. I mean, anyone can. Yeah. And someone's asked, can you go back over how you would calculate whether a patient is hypoxic when they're on oxygen? Yeah, of course. It's just basically what you need to do is, so if they're on oxygen therapy, you need to work out what percentage of O2 they're on. That's why I gave you this information about oxygen delivery devices, because it gives you that sort of information about the rough percentages of oxygen that they're on. And once you've worked out what percentage of oxygen, not the litres, the percentage, take 10 away from that percentage, and that will be what their oxygen should show on an ABG. If it is lower than that, that is a sign they are hypoxic. So if they're on 40% of oxygen, then because that would be, so if you give someone 15 litres of O2 through a simple Hudson face mask, they'll be getting about 40 to 60%. And then if you do an ABG on them and their ABG comes back showing their oxygen levels to be 10, you know that that's significantly lower than it should be, because it should be 30 to 50, based off how well they're using this mask and how much is getting oxygen's escaping out the sides. If that makes sense. Yeah, it could mean that they are hypoxic as well, because I've seen patients who have come into ED who have been significantly hypoxic, and they didn't know they've been on 15 litres, and it was that they were hypoxic rather than their ventilation was causing them to be hypoxic. In that case, I don't know, maybe it's variable on the patient, but I definitely have seen that. Does anyone have any others? If you have any more, maybe just to pop in sort of to the bottom of the chat now, because there's so many things coming through, it would be quite nice to just, if there's anything that you're concerned, any other questions you have?
We had a couple before, you know, the DKA case.
Yes.
People were saying, what else could it be if it's not DKA?
Okay, yeah, that's a good question. So it could be that they've got some sort of infection that's causing like sepsis, and sepsis can cause an increase in their lactate, so this is what I was saying about all of these other causes of metabolic acidosis. These are all causes of that. So it could be that they're in some sort of sepsis due to this infection, and that's causing a metabolic acidosis. Or it could be, yeah, I think probably the most likely, when a patient who came in like that, the things that you'd be looking at would be DKA, sepsis. I think they'd sort of be the top two. When you do an ABG, you get given the glucose levels. That's just something that you should probably be aware of, that on an ABG, it's another thing within the list. They give you a long list of things, including a rough estimate of the kind of ions and loads of things, and glucose is on there. So if their glucose is sky high and then they're acidotic, that's sort of a sign. But yeah, other causes could be sepsis. I think they'd probably be the two that I'd be looking at. Maybe Addison's. I know that can present in quite weird ways, weird, wonderful. So yeah.
Thank you. And that, I think that kind of goes hand in hand with another question we had, which was, can high lactate cause metabolic acidosis?
Yes, it can. Because it increases the acid. Yeah, can I go over how to identify compensation? Yeah, the way that I would do it is look at the pH, write it down if that's going to make it easier for you. And then if it's acidosis, think of what are the two causes of acidosis. So an increase in CO2 or a decrease in HCO3. Then look at both of them numbers and see which it corresponds with. Because that is, so if it's HCO3, then you know it's a metabolic issue. And if it's CO2, you know it's a respiratory issue. Then if the other one is abnormal, so the other number is abnormal. So if you identify that it's a metabolic issue and you look at the CO2 and that's also abnormal in the opposite direction, that's a compensation occurring. So it's just looking at once you've identified which one is causing the issue, by seeing which one corresponds with the pH, you need to look at the other one to clarify whether it's abnormal and if it's compensating. So yeah, that's probably just something to be aware of. Base excess is just a marker of so let me just get kind of up a bit of information that I had on it, but it's literally just a marker of metabolic acidosis or alkalosis. You don't need to calculate it, it will be given to you in your ABG, and to be honest, I don't think it's really needed to be given to you. I don't know, I've never seen anyone say that that's something that they use. It's just another way of looking at the whether it's metabolic acidosis or alkalosis. So, and if that's abnormal, then it correlates to your bicarb levels. So yeah, it's just to back up your bicarb, but it will always correlate. I've never seen it not. Yeah.
And I think we had another question that was saying, what sources would you recommend to study ABG's interpretation from?
So I personally really liked YouTube for this sort of thing, because if you want something explained to you, like this, and you want to go into the pathophysiology, there's so much on YouTube. I really like Osmosis's videos. I know you might have to pay for them now, but they were quite handy when I was doing like the pathophysiology and the basics of this sort of stuff in like 3rd year, 2nd year kind of time. So I'd say that's quite good, Osmosis. And there's another one, I think he's called like Armando something, Hasugan. I can't tell you that off the top of my head, but if you just Google ABGs, there's just so much out on YouTube, and I would say that that's probably your best. So if you put in like arterial blood gas interpretation, don't just put in like a really generic sort of search. That will help you to get some kind of more information. It is something that I personally think you click with, and once you've got it, you're like, why did I never get it? But I can understand that it's quite tricky until you've clicked with it, and it might take various different people explaining it to you for one person's explanation to click. So just being aware of that as well. Don't beat yourself up if you're finding it tricky. Yeah, someone's just said Ninja Nerd on YouTube. There's so many things out there, guys. Like, we're so lucky we do a degree that is literally so there's so much available to you. Like, we don't have to just sit and trail through research. There's so much out there. So just use the resources that are available to you. And yeah, repetition is key. Correct. But yeah, I mean, that's pretty much everything. Unless anyone has any other questions or anything else they want to check in with, that's pretty much everything I have to say. So you can